Give me a 5. Hello, I'm Dr. Russel Libby, and I welcome you to the world of medicine. Backs, they're a source of a lot of pain, whether it's in your neck, your lower back, anywhere, up and down. It's something that we all share, probably as a population, in a common fashion. At some point in our lives, 85% of us will experience a significant back problem, one that more or less interferes with our routine daily activities, may have us avoid some fun activity that we might have been doing with our family, not go to work, do something like that. In fact, back problems are the leading cause of missed work days in our population. And talk about searching out and looking for cures, relief, and for diagnostic acumen. We spend somewhere close to $90 billion a year in our country to take care of our backs. It's a big problem. So backs can be caused, well, let's say the problems with backs can be caused by any variety of disabilities or problems. It seems to spread itself over a fairly diverse spectrum of medical specialties. All kinds of therapies, whether they're conventional or unconventional, will be exposed with people looking for relief for their back. So we're going to hear about what kinds of back problems people have in this show today. We're going to learn a little bit about what people go through as they develop their symptoms and how they get diagnosed and how they get treated. We have a great studio audience. They've had some real hands-on, or let's say they've had their back up against the wall with their problems, so they've experienced it. We have a specialist in Michael Haas. He's a spinal surgeon. He works at the Virginia Spine Institute here in Reston, Virginia, and he's one of the premier spinal surgeons here in Northern Virginia and the region, for that matter. So I know that we have some great stories to tell, but I want to hear, just to start, from you. What was it, I guess, how long ago did you start to have a problem with your back, and what part of your back was it?
My name is Julie Shepard.
Hi, Julie.
About 3.5 years ago, I was in a car accident.
Right.
So I've had complications since with my neck and very severe headaches. And went through physical therapy many times. Injections did help, but they only lasted a short time. And
so your problem started not too long ago.
No.
You've been very fortunate relative to,
yes.
to most, but it was a precipitating accident that
Yes.
did it for you. And I know you've had a back problem. How long ago did you start having problems with your back?
That was about a year ago.
About a year ago, so pretty
Yeah.
recently.
Yeah, and mine's happened at work, falling off a ladder, and I had a pop in the back.
So that was a real injury. I mean, you really had a pretty healthy back up until that time.
Yes, sure did.
Any family history of back problems?
No,
No? So your parents were pretty much sturdy and free of those kinds of things?
as far as I know.
That's
Yep.
great. That's great. How about yourself?
I've had back problems on and off since I was a young child. I have scoliosis, and this recent one I did about 1.5 years ago, and it was by far the worst.
So you've had back problems in terms of chronic pain and
Yeah.
difficulty with dealing with it, and then through the life there have been episodes where pain has gotten worse.
Right, but this one I actually herniated a disc, so it was a definite incident, and it was by far the worst pain I've ever had.
And back pain is one of those measurable things that sort of go off the scale. And
You know what 10 means.
yeah,
when
you know what 10 means, that's for sure. And it doesn't stop.
No, 24/7, no
Yeah.
relief.
Yep. And you're...
I'm Karen's caregiver. I'm her husband.
You are? Well, that's great. So you've had to realize exactly what it means to be...
She was in a lot of pain, right?
Yeah.
And then when she came home from the hospital, I dealt with that too.
Yeah. Have you had back pain since?
Nothing for me.
You don't complain?
I don't
You
complain.
try not to anyway, right? Okay. So you've been pretty fortunate then
Very
yourself.
fortunate.
That's great. And I know we have a history of some back pain from you as well.
Yeah, I could be pretty handily described as a double dipper. I have the misfortune of having had to seek treatment twice.
Right.
In the late 90s, I suffered an injury while exercising at the gym, and that was diagnosed as an annular tear, a particular type of disc injury. And fast forward to 2001, I suffered a very peculiar jamming of my lower back and pelvic joint called the SI joint. I basically fell straight down on a dead straight right leg from about 3 feet up in the air, and it caused this incredible pain and jamming sensation. It basically felt like my hip bone touched my rib cage halfway up. I was that compressed. Right. And in both cases, I tried to tough it out and shrug it off. But after a while, a few weeks, maybe a couple months go by, you realize that something's not quite like it should be. And very fortunate to have found the help of Dr. Haas and his staff.
So we're hearing that, well, in this particular situation, a lot of these have been caused by injuries. What do we see in terms of the common causes? I mean, there's a whole spectrum of back pain, literally from the top of the neck to the tailbone.
Yeah.
But give us a little overview as to where the pains generally are, and what are some of the common background of causes that you might see for.
Well, there's a whole range of back pain. People can have back pain from a muscle pull. If someone lifts the wrong way, next thing you know, you actually sprain a ligament or just strain a muscle, and usually that gets better in a week or so, maybe even sooner, just with some Advil or Motrin or something like that, and get you back to good exercise-based therapy if need be. So many people can have muscle strains, and in most people that have car accidents, most will get better without any type of injections or surgery. We just try to calm down the inflammation and get out of the bad habits of poor posture and try to get the muscle strength back and get back good function. But if someone has long-standing pain, let's just talk about the neck, for example, that ubiquitous term called whiplash. What is whiplash? Most people will have injuries to the soft tissue, like the muscles and the ligaments. That usually gets better. Now, sometimes other things that can get injured are little joints in the back. These could be facet that can be injured. These are these little joints in the back of the neck. If this is facing forward, there's small little joints here that can cause pain. And sometimes even the discs up front can actually cause pain. You may have heard about disc herniations pinching a nerve causing in the back causing sciatica, or in the arm causing arm pain or tingling or numbness like a stinger some football player may have. Right. And that would be a pinched nerve. But discs themselves can actually cause neck pain. They actually can cause headaches. So, and similar in the back. So you can have muscle pulls, you can have ligament strains, you can have joints that are out of kilter that can cause pain. Lots of things like that.
So, and it's interesting, just give us a little better education on the anatomy, because I think it's a good place to understand where we're starting. And you have your model here.
Well, here's a model of a low back. This is a lumbar spine. This is as if I'm sitting right here. Okay. Some of the things we see here are the bones. We all know what the skeleton is like, so these are the bones called the vertebra. And people can obviously break bones. So if someone falls out of a car accident or falls out of a tree or something like that, they can break their bones. Sure. Someone that has osteoporosis can do something as simple as sneeze because their bones are not strong enough, they can actually have a compression fracture. So that is one area that can cause pain. The discs are the shock absorbers. These are the things that allow some mobility. The discs can also, if they're injured, cause pain. The annular tears that we talked about earlier, the annulus is the outer part of the disc. If you imagine the disc to be like a jelly donut, if the disc gets injured, it can cause back pain. So a lot of people hurt a lot, even with prolonged sitting. That's the type of pain you can have in the middle of the back. If a disc herniates or has a flat tire, you could say that this red part of the disc would be an example of a herniated disc, and if that pinches on a nerve, that can cause pain that goes down the leg. That's what your grandma would call sciatica. Right. Okay? So those are a few of the things in the back. So we've got the discs up front, we've got the nerves that come out, we also have the joints in the back called facet joints, and just like a knee or an ankle, these are real joints. These joints can also get arthritis. Those joints can cause pain as well. And then there's also that sacroiliac joint that was mentioned earlier. The sacroiliac joint is that big joint that is between the lower bone called the sacrum and the big bone that some people call the hip, which is really the ilium. And that joint is frequently a cause of pain, particularly in women because of the broader pelvis and the way the legs come together because of that. And also, like in pregnancy, you can have this area that's frequently cause of pain. And also trauma, if you land on that, you can have back pain as well.
Right. So you have, as you were saying, you have the strains, and those are the muscles and the ligaments that support the vertebrae and all the tissues related to the vertebrae there in the back. That's one source of injury. You have the disc, which in and of itself can cause pain, whether it's against a nerve or just fragmented and irritated and injured.
Yes.
And then you have it when you get that disc that protrudes or the herniation, that can press on a nerve, and that'll give you that nerve pain that you were talking about.
Yes.
That's like the sciatica where it goes down into your buttocks and into your leg.
And then the other things that we always have to think about that today's talk is not focusing on, but some people can have back pain because of kidney stones.
Right.
Some people can have back pain because of an ulcer going back. So there are other things that can be a symptom of back pain, but we're focusing mostly on the musculoskeletal today.
Yes. So are there other kinds of diseases? You were talking about arthritis. You're talking about arthritis in that facet joint. That's the joint that supports one vertebrae against the next.
That's the joint that helps keep the spine from sliding back and forth.
Right.
It gives stability.
Yep. And that, you're talking about arthritis. Now, are people with arthritis or specific types of arthritis more prone to back pain?
Some areas, if you have anything that's called a spondyloarthropathy, which basically means inflammation of the spine and joints, they can have increased pain. We know that people are prone, there's like 3 things you want to think about for back pain. You think about the family history. You were talking about that earlier.
Right.
If a family has a history that their collagen heals or grows in a certain way, they may be more prone to having their discs wear out. We also know that people who smoke, smoking affects collagen, and collagen is one of the structures that goes along with the discs,
Okay.
and we know that that has a higher incidence of back pain.
Okay.
Many patients are somewhat surprised that back pain and smoking are definitely related. Pretty much everybody knows it's related to emphysema and other lung problems, but they get surprised when it's related to back pain.
Right.
And then the people with like rheumatoid arthritis and so on can have instability patterns and go along with that.
So there are some predisposing factors, but genetics seems to be a big one.
Yes, and also activities. One thing we didn't talk about, it's very common in very active gymnasts or football players as they're growing that they could have gradual traumatic injuries to some small areas of the spine, and that over time the spine can become unstable and actually start slipping, so it's not lined up on each other. So one vertebral body can actually slip forward, and that's called spondylolisthesis, and that can lead toward pinching of the nerves, which can cause leg pain or hamstring tightness or even cause back pain. So there's more things like that.
Okay, and you'll see that usually in the younger athletes?
Frequently, yes.
Yeah, and pretty dedicated and aggressive athletes.
Yes.
That's good. So you were talking about scoliosis. Now, is it something you discovered after you had back pain, or was it something that was screened and sort of picked up at some point in your life?
I had back pain in high school, and they diagnosed me with scoliosis and gave me a back brace, and I had to wear it for 2 or 3 years, and it actually helped a lot, but it was something I had to struggle with later in life too.
So that was just a few years ago when you were in high school.
Yes, 1 or 2.
Right? And at that time, they probably did an x-ray.
Mm-hmm.
And that was probably about the extent of
That's
that
all they
workup.
did.
Right.
Was
Did they ever
X-ray.
do any other kinds of, I guess they used to do different types of injections of dyes and look at them under fluoroscopy. Did they do any of those things?
When I went in the military, and I had more back pain, then the military did that type of thing for me.
So scoliosis started with pain,
Mm-hmm.
and it was picked up because of the pain. It wasn't just a routine screen. Did
Right.
you have a family history of anybody with scoliosis?
No, I'm the only one.
Because there is a pretty common association. Scoliosis and back pain, I mean, certainly we know what 10 or 12% of the population has some degree of scoliosis.
Quite a few people have scoliosis. It's more common in girls and boys, and most of the time it's pain-free, and it can be picked up on a school type of screening. It's often manifested with asymmetry to the shoulders or a little rib hump that can be seen when you bend forward. So in the growing years, if the curve is the right size, often we can arrest the further development by placing in a brace during the growing years. Once you finish growing after about 18 or 19 years old, you usually are out of the brace. And it's important to maintain your exercises in the meantime. No one really knows why we get scoliosis. There's some theories of things like inner ear balance issues that can go along with that. But there's been a lot of attempts to try to figure out why someone has scoliosis, but most of the time it's called idiopathic, meaning we don't know. There's other types of scoliosis due to deformities of the actual bones and the discs in development or later on, or if someone has a neurologic issue. But again, most of the time it's idiopathic. Most of the time it doesn't hurt. The main issue, if it gets big enough, is if you have a big enough curve, then you start losing space for your heart and lungs. So if your curve gets bad enough, next thing you know, you're bent over, your rib cage is pinching on your iliac crest, or you start losing room for your heart and lungs, you can't take deep breaths. Now, that's one reason you start considering surgery if the curve is not controllable in a brace, or if the pain is bad enough, or if the curve is big enough, particularly when you're young, you want to be able to try to straighten that up and give more room for the heart and lungs.
So it's a good thing for people to screen if they have an adolescent who's complaining of back pain, just to go to their primary care doc. Most can screen for that sort of thing, and if they detect that kind of curve, then they can refer them to somebody who knows a lot more about it, like you.
It's important to screen.
Yeah.
Yes, it very is.
So that's one important source. And do most people who end up with really chronic back problems start somewhere in adolescence? I mean, other than the traumatic episodes, I mean, do people start having, people have cycles of pain, like you were saying, you pull a muscle. And of course, then later on in life, you have a ruptured disc and you have that sciatica, and you think back to when that time happened, when I had that pulled muscle. You didn't know what it was at the time. But do we see an association through a lifetime of people who have frequent musculoskeletal injuries that end up with more severe problems?
Well, we know that most people have episodes of back pain.
Right.
Some of the studies suggest that about 80% of people have an episode of back pain every couple of years.
Right.
Since most people have an episode of back pain, it's easy to 10 or 20 years later to say, maybe that thing back in high school caused my problems now that I'm 40 years old.
Right.
I don't think it's usually related, since most people do have those issues. But if someone starts having the degenerative changes or the injuries, just like the football injury with the knee, if you blow your ACL out and your knee is now unstable, you're probably going to have arthritis in your knee more likely than someone who didn't injure their knee. Right. Same with the back.
Right. So you had a pretty distinct episode. Did you know right away that you did something that shouldn't have happened? No,
when it popped, it felt like a knuckle cracking.
Right.
So I didn't think anything of it. Just got on the train, went home, got back to my area, and by the time I got home, I had the throbbing in the legs. At that point, I knew something was wrong. I couldn't stand, I couldn't sit, couldn't lay down. The only comfortable position was in the fetus position.
Yeah.
So from there, I went to the emergency room, and that's...
Yeah, and that only worked when you were a fetus, right?
Yeah. Yeah, I mean, it was the only time the pain was actually gone or relieved.
Right. So, and then you went right to the ER, and what did they do there?
First thing they did, because it was a fall, they did x-rays to check to see if it was anything broken in the back, and then they found nothing broken. They knew something was wrong, and at that point they said I needed to go to a specialist. They just gave me a shot and other stuff to kill the pain. Yeah. So you laid around the next day. Did you get in to see someone the next day? Actually, no, I didn't. Yeah, I kind of did lay around the next day. Called around, nobody would, nobody was able to take me, and then finally I remembered it. I actually did some work at VSI, and I was like, give them a call, and sure enough, Dr. Oz was able to take me.
Well, that's good. So yeah, did you find any relief in that day of rest? Did you put ice? Did you put heat on it? What happened?
No, I just took the medication that they gave me. I think they gave me Valium.
Right.
And that was pretty much it. I mean, it was still pretty painful.
Right. When you describe pain, had you ever experienced anything quite the same?
No.
Unrelenting?
Yes. It hurt. It was pretty bad, yeah.
And it hurt in your back, or did it hurt in your legs, or?
All the way down, from my back all the way down my legs.
Both legs?
And then the groin, yes, both legs. All the way from the front of the legs to the back of the legs.
So you had it bad?
It was bad, yeah.
And that's not really typical. I mean, obviously with an injury, if you have an acute injury, you can have a pretty dramatic pattern of pain. But is it not usually a little bit more insidious, sort of evolving over time?
Most people don't have a traumatic episode. It can often be more of a wear and tear. But folks that have an injury like that, most of the time within a week or so we can get it calmed down, either with medications or sometimes injections, and then we get them involved with physical therapy to get moving right away. The days of laying in bed for 6 or 8 weeks are out. A couple days, maybe, but after that we want you to get moving. We don't want to lose the muscle strength. We don't want to lose the coordination, because even if your back pain doesn't get better, we want you to be strong and fit if you need surgery so you can recover faster. Most people don't need surgery for back pain. And what we try to do is do some of the things that you tried initially. We tried to do the medications, we do some of the injections. Did we do injections? Did we try some of that?
After the first surgery.
Yeah.
We did the injections.
And then after that, then it's important.
After the first surgery, is that what I heard?
Yeah.
Okay. So you had to go through a procedure. How quickly after your injury did you have the procedure?
I think a week later. I think it was, yeah.
That was
it
once
a
for your
couple
leg
days.
pain, right?
Yeah, I had to get the MRI, and I had to get the MRI back to their office.
Right.
By the time they saw it, when they did see it, they said they admitted me to the hospital right away that same day. So about 2 hours later of that day, I don't think it was a week. I think it was about 3 or 4 days, if it even that long. So it wasn't long right after.
So we have here an episode where he had a traumatic episode that really wasn't resolving over a few days. Acutely, you felt you had to see what was going on because of the nerve pain.
Yeah. Some of the studies we get, we talked about the x-rays. The x-rays show bones.
Right.
X-rays are good to show what bones look like, but they don't show soft tissue like nerves or discs. And if you're having symptoms that go along with nerve impingement, such as that herniated disc we talked about, remember the model here with the big herniation that can pinch on a nerve, your MRI, remember what it showed?
Yeah, nerves are actually being crushed.
So the nerves had a large herniation. It was pinching on the nerves. So because he wasn't getting better, because it was that bad, we didn't expect that it would get better. We know that about 80% people will get better even with the herniation without doing surgery. But sometimes you don't want to wait that long if it's hurting that badly because the nerve is really getting crushed. So in this case, in order to try to help the leg pain, to take the pressure off the nerves can often help that. So we'd end up doing the surgery because it was such a large herniation. And he knew that surgery for leg pain to take pressure off the nerves is what's called a microdiscectomy, right? And then if he was going to have back pain later, that's what he talked about a possible second surgery. Back pain isn't reliably treated with just a discectomy procedure.
So and we'll have to hear about some of what that means. You had your car accident.
Yes.
Did you realize immediately when that happened that you had something you had to take care of?
No, I thought I was fine. I got up and did everything I wanted, and then all of a sudden I started having pain, and I tried to brush it off, but it just got worse and worse.
You seem to be that type that would try to sort of overlook those kinds of things until they really were incapacitated.
Well, you don't want to be a whiner.
Right. Is that a fact? She's not a whiner?
No, she's not.
Not at all. No. Good. So how long were you able to wait before you decided this is not working out?
I think I saw Dr. Haas maybe about a few months later.
Right. So you gave it some time.
Yes.
And what kind of investigations did you go to the ER after your accident?
Yes, in University of Virginia.
Okay. And they did the functional x-rays as usual. And they said, well, there's nothing abnormal here on the x-ray.
They just gave me pain medicine, and I thought, oh, I won't need that. And
right. But you held on to the prescription.
I think we filled it later.
Yeah. Okay. So you spent a couple of months. You thought that over time you would get better and things would relieve themselves.
Yes.
Did you experience any of that?
Well, for a while.
For a while. Now, the neck is, something that you often will hear more of the chronic complaints about. But you probably experience in that short period of time what people sort of experience over a lifetime in the evolution of spasm and pain. Tell us a little bit about what you were experiencing with your pain.
The pain at times was excruciating.
And it was all localized to the neck? Or
pretty much the neck, but the headaches were the worst.
Okay. So they actually generated headaches for you?
Yes.
And you weren't prone to migraines or anything of that
nature?
Not
at all.
No.
Not at all.
And was there anything that you could do to relieve them?
Well, they gave me some medicine to take, but you don't want to take medicine because then you can't do anything and go anywhere.
Right.
But then it got so bad where you had to plan your day around the medicine because you couldn't drive.
Okay.
So it made it very difficult planning a day and then just living in pain when you wanted to do so much and you couldn't.
No. Did you have pain into your arms? Any weakness?
Just
in
a
your
little
arms?
bit down my left arm.
Okay. And so you were lucky in that respect,
yes.
relatively speaking. Have you ever had a crick in your neck? One of those where you sleep the wrong way, you wake up in the morning, your neck
I have,
stiff,
yes.
and by the end of the day, it's about half
actually,
mass, right?
25 years ago, I've had a ruptured disc and went through traction and treatments and so on for period. But I've had no problem with it since then.
Right. Okay. That's good. I mean, most people will experience at one point or another some episode of pain in their neck. It's interesting to me because, it's one of the most debilitating moments you can have. Those are all soft tissue generally, no? When, you sleep wrong in the morning, you go, oh, I'm a little sore here. And by, midday, you can't even hold your head up and you're looking for one of those foam collars just so you can rest your chin on it. What's going on then?
It frequently is. It's a little difficult to say what specific one thing can be causing the pain. Anytime you're in an odd position for quite some time, you can't put stress even on the joints. For example, a facet joint can get locked up. And those are those little joints we talked about in the back of the neck.
Right.
And also the ligaments and the muscles strained a long time. Just in any one position, they can get the cramp, just like you can get a hamstring cramp.
Right.
So it's tough to say when you look at the black box just of the neck with so many things that can cause pain. And that example that you're having, it's tough to say. But when you see how someone moves, you can get a feel for that. When you can feel along the muscles of the neck, you can see if there's any spasms in any particular, and then you can start narrowing it down.
Right.
But again, usually, just like an ankle sprain, just like any other thing, we try to calm it down, anti-inflammatories first, and then try to get them out of that habit of get that spasm, and often send them back to the therapist. The therapist can often help work out the initial spasm and try to get things back in line.
So you can have that initial introduction of trauma or just sort of evolving degeneration of your spine and the muscles and supportive structures around it. And you're saying the first thing that sometimes you'll try, I guess let's talk about diagnosis first. At what point do you think people need to get studies? And I'm talking about MRIs, and they aren't easy to get anymore.
They're tough.
Your insurance is going to interfere if you don't have a good reason that fits the criteria that they have in their authorization book. You won't be able to get it unless you want to pay out of pocket. Most people don't want to do that. They're not cheap. So, where's a place to think about starting to get those kinds of studies?
Well, since we know, if we're just talking about neck pain, if we're talking about neck pain, most of the time they can be treated non-operatively. If someone doesn't have any acute trauma, if someone doesn't have a clinically real severe pain. Someone could have real severe pain and actually have an infection. So a lot of times clinically, if you take the history, if you get a good history of someone, and if you see people that describe neck pain and back pain all the time, you can get a feel for someone that's really outside the box of what you would expect. So if someone's in a car accident, someone falls, someone should get an x-ray. You want to see if there's a fracture. Whether or not you need an MRI right away is based on symptoms. So if someone has weakness or some nerve impingement or it's actually progressing, you want an MRI sooner. And even most of the insurance companies, you can twist their arm a little bit and get that if you have some progressive issues. If someone has ongoing pain, for example, for quite a few months, then it's worthwhile to start looking at other imaging studies. But within the first week or so, not too often do you need an MRI. But if you have someone that has bad enough symptoms like was described earlier, getting an MRI is appropriate. The insurance companies do take large samples of what's been medical experience and try to make rules for them to try to keep overutilization. Unfortunately, it doesn't take into consideration the individual. So if 80% of people are going to get better, you can't say that the other 20% fall in that 80%. What happens to those?
Right.
So sometimes we have to argue for those tests. But getting an MRI within a day or two of having just neck or back pain, usually not needed.
Okay. Well, that's interesting. Did you had an MRI?
Yes, I did.
How long did it take you to get to the point where you could actually qualify for one?
I think kicking and screaming would be a pretty fair way to describe the insurance company's reaction.
Were you dealing with your pain?
I had been laid up for about 7 to 10 days, being pretty inactive. I think about the first 5 days I spent almost immobilized. I was in the emergency room initially, and I went back and forth with the insurance company for the better part of, I think, 2 weeks before Dr. Haas finally was able to get them to let me have one.
Okay.
Yeah.
So it was something you had to basically demonstrate a valid reason to get. Did they do any other modalities to diagnose your problem? Did they try any other kinds of things other than the MRI?
Well, the MRI was something that Dr. Haas prescribed as being a good extra measure. Right. We had been through a number of functional tests in his office, and given my history since my injury that resulted in the MRI was my second back injury, it was decided that it was a really good idea to have one done sooner than what Dr. Haas might normally send somebody for.
And any other things that were used to see if they could make you feel better that were also diagnostic? Injections or anything?
No, fortunately, we didn't have to go that route. We did prescribe some. I did have a prescription for some anti-inflammatories and a steroid if we had to resort to that. And the injections were on the table as a possibility, but from the get-go, it wasn't suspected that we'd have to go that far.
Okay. And you're a physical therapist at this Virginia Spine Institute.
Yeah, at the Virginia Therapy and Fitness Center.
The Therapy and Fitness Center part of the...
We are part of the Virginia Spine Institute,
okay.
yes.
And you've actually worked more arduous periods of difficulty.
That's correct.
With this young man?
Yes.
Getting him through some of the... And as Dr. Haas was saying, sometimes we try to avoid surgery. We try to find ways to get people going. What do you will get them. I sort of feel like he's sending you people saying, salvage them, please, take care of them, get them better so that I don't have to cut on them, basically.
But I would definitely agree that, I think the first step, given you don't have a severe case, I think it's a pertinent trial to try physical therapy and try to get good physical therapy to identify if the person's going to respond to physical therapy with conservative measures.
Right.
And after going through a good course of physical therapy over 6 to 8 weeks, if they're not responding to physical therapy, or if they're not responding even before that, communication between the physical therapist and the physician is appropriate. But following a course of physical therapy, you can make some strong determinations whether that person is going to respond or not. And if they're not responding to physical therapy, then that information goes back to the follow-up with the physician, and then further measures can take place, whether it be injections at that time to manage their inflammation and their pain, or potentially surgery given their situation. Right. But if they are responding to physical therapy, then you continue to progress them to get them to the function that that person is interested in getting to, and matching up with their previous functional status or their goals.
Okay.
And Russell, just one thing.
Yes.
Often in conjunction with that, it's not they're off doing one thing at one time.
Right.
We're often doing the medications. We're often doing active hands-on physical therapy.
Right.
Or often if someone has inflammation somewhere, if it's not responding within a couple weeks of some hands-on physical therapy, maybe putting some localized medicine in areas of suspicion.
Right.
We can put some injections around the facet joints or in the sacroiliac joint, calm that down locally, get them back into the therapy. So it's a combined approach to try to put all these things together.
I want to hear more about the injection therapies, because I know that that's a step in between more severe approaches to care and surgery. But, a lot of people might say, oh, there's 3 pages here in this Parade magazine on back exercises. Why do I need to see a physical therapist? And I think it's important to tell us, a little bit about, the process of evaluating a patient, getting a personalized fitness program and things of that nature. Those seem to be pretty important.
Well, they're very important. I would say, for the most part, as we get older, many people lose their mobility. They're not as active as they used to be. So flexibility and some general mobility exercises could probably benefit most of us. But the best physical therapy that they can get is going to be a program that's going to have a comprehensive evaluation. And in the evaluation, the therapist is going to get their hands on the patient, and they're not only going to be evaluating how their muscles are moving or how flexible their muscles are, but also evaluating specific joints. And in our case, we're getting our hands on the patient, actually assessing how their back joints are moving, so the facet joints that Dr. Haas was referring to. And with our hands, we have an idea with our education how joints are supposed to move. So we know what a normal joint will move like. And we can assess a joint that's restricted or is moving too much. And what's important is if you pick up a joint is not moving well enough, our goal is to mobilize that joint to get it moving better, to normalize that patient's mobility. But on the other side, if somebody's joint is moving too much, our goal is not to get that joint moving more, it is actually to stabilize that joint and get the muscles surrounding that joint to actually enhance the stability through the muscles. So you have two situations that actually require completely different and opposite treatments. And evaluating the patient to determine what they need is critical. So the evaluation is the first step. And then taking them through the exercises are a reflection of what is needed based on what the evaluation findings show.
So it is an important element of the care for someone who wants to find relief and wants to go non-operative and self-care. care kind of route.
It is important enough that at our institution we've actually had the docs and the physician assistants and other caregivers actually go through the program, and we obviously have read the books. We've also make the recommendations, but going through the program we have an idea of getting the feedback to make sure we're doing it right. Sometimes by reading a book you think you're doing the right exercise, it sounds right, but if you have the actual hands-on feedback, and once you have that feedback you can take that home and do it on your own again. Right. So an essential part of this is to learn how to do this, take that skill, and not be reliant on a therapist down the road. That's an education to help you in your life better.
Right.
So it's very important to learn the skill, have a good practitioner tell you exactly how you need to be doing that, because we get in bad habits over years. We don't even know it. But once we learn that, then we can take that on and do it our own program.
And we've heard from someone who has had a severe back problem, who has found that doing the therapy and waiting, not necessarily rushing to some emergency procedure, has worked. And will run with that as long as they possibly can, I'm sure. When we talk about those injections, we talk about some of them are relieving of pain as well as sometimes even curative to some extent, and also are used for diagnosis. You were talking about injecting the facet joints, and what is an epidural?
An epidural injection, for example, an epidural is a place in the spine.
Right.
So the epidural space is the space. In this model, you can see this is the lumbar spine again, this is the low back. This yellow representation is the sac that holds all the nerves. Okay. The space above the dura is the epidural space. So if someone goes in and has a baby or goes for surgery, in that epidural space, the anesthesiologist will put numbing medicine to help make the whole area comfortable. When we use the term epidural, epidural is to put medicine in there to try to calm inflammation down. So frequently that'll be some local anesthetics such as lidocaine and some steroid medication, right, which is the strongest anti-inflammatory we have. Right. So an epidural is a place where we put medicine where we're suspicious where pain is coming from to calm inflammation.
Right. And so that will have obviously numbing medicine, which if it's in the right spot will give pretty nice relief, but it's that steroid that tends to give them the longer duration of relief.
It's amazing that even though the medicine's out of your system within a few days, there are people that have an epidural injection that can have improvement for weeks, if not months. Right. And we can help avoid surgery, allow them to do their exercises and get on with their daily lives while they calm that inflammation down. And then as it gradually gets worse, the inflammation comes back, sometimes you need to do the epidural injection again. And it's like putting ice on a sprained ankle instead of putting you in a cold room. So if I give you an anti-inflammatory that goes out through your whole body, right, but if I put that same medicine right on where it hurts, it's like putting ice on the sprained ankle again, that can really help localize your treatment.
And for some who have an injury and inflammation secondary to injury, the time that they buy with that steroid or that epidural can give them time enough to heal so that as it resolves, they're better.
Yes.
So it can have a curative function of sorts, I guess, at least breaking that cycle of pain and inflammation.
Yeah, breaking that cycle is very important. Then we can get back to your activities.
So you can use the injections, and you were, of course, talking also about the facet injections, which are different.
The facet injections, again, putting localized medicine at these little joints here. These joints, it's actually quite complex in here. You need to get into that, but there's some innervation at more than one joint. You can't just point at someone's back and say, is that where it hurts? You can narrow it down, right, but often the injections can calm inflammation down and be theoretically curative, but on the other hand, even if it helps for an hour, that local medicine can tell me that that's where some of the pain can be coming from. And then there's some other non-operative treatment where you could actually put a little wire down by the nerve that innervates that joint, and you can deaden that nerve with heat. And that can help decrease pain for 6 months to a year or more.
Okay. So, you know, and one of the things, of course, I know because I've been through the back sequence myself and spent, you know, decades literally dealing with the progression of back pain. But I know that for me, I have a family history where we tend to dry out our discs early in life so that they don't have the same nice cushiony quality, and they tend to get more narrow. And that brings those vertebrae out of their normal distance and creates stress on these joints. And I've had a lot of arthritis develop in those joints because there's a different pressure as they don't align the way they're supposed to be. And that has created calcium buildup that has impinged upon or pressed upon the nerve that comes out in that area.
And then you start having leg pain. Then you start
having really bad leg pain.
And then as your disc wears out, then you start getting a flatter back. And then you start bending forward.
Right.
All those things that go along with the arthritis of the back that we call spondylosis.
And with that, this is the progression, of course, that is of substance in terms of where you end up with surgery. And I know that for me, as I progressed that way, I got to the point where when I wanted to sleep, I had to lay with 3 pillows under my waist. I could sleep in only one position. And that was so that I could relieve that lordosis and get some flexion so the nerves weren't being pressed upon. Otherwise, I would wake up with my leg just humming like it was like I put a 220 wire right to it.
And we know that short term, some people can have some relief with some traction, but it's never been proven to have a long-term effect. But if we can calm inflammation down, sometimes in physical therapy we'll try some traction. We know that some people with the back pain due to a disc, and you can talk about that a little bit, is that one of the questions we ask is, do you feel better if you go out and back and hang from the swing set and let some pressure be taken off your back? Or do you feel more comfortable if you're in the pool, taking pressure off the discs? That's another clue. And those are the same folks that when they sit down, and we know there's a lot of pressure on the disc when you sit down, that people with an office job with disc pain hurt more sitting. And their colleagues that don't realize that you can have back pain sitting, they say, you've got an easy job. Why are you complaining? They'd rather be up moving around because they feel better. So not everybody's aware of disc-type pain.
Right. So they think they have ADHD. They're wandering around the office. They won't sit down and finish their work. They can't.
They hurt.
They hurt. So there comes a point where I guess you have no option. I know that for me, the point was where I couldn't stand for 5 minutes. I couldn't walk 100 yards. But there are neurologic symptoms that you'll see quite often. What are some of the problems and what are some of the little tests you do that people might be aware of if they've had chronic back pain and sciatica that they've tried to ignore over the years?
Some of the things, if you want to talk about the leg pain, we find that if a nerve is pinched, we know that if someone sits or rides in a car, puts their leg out in front of them like this, there's additional stretch on the nerves. They might start having more pain down their leg with that stretch. Similar to if someone has a pinched nerve in their neck, they might tilt their neck to the side, pinch, cause pain going down. That's one thing we need to check out to try to differentiate that from being pinched nerves other places. Someone that has their hands fall asleep at night might actually have carpal tunnel syndrome. They wake up, shake your hands, feels better. Try a wrist splint. If they can sleep without their hand falling asleep, or sleep without their hand falling asleep, it may be carpal tunnel syndrome. But if that doesn't change, maybe they're truly having a pinched nerve in their neck or their elbow. So you look at some of those things. So if you wake up with your whole arm falling asleep, you may just have pinched a nerve or a blood vessel there. So there's different things that you can think about. Most of them, again, you don't have to be really worried about, but if it continues or gets worse, then you have to think about getting evaluated to see if something's being pinched to fix it.
And I know that for me, it was when I couldn't walk on my heels. My feet would flap right down, something they call foot drop, which...
That's true weakness to the nerves. If you have true weakness, if the nerves are completely pinched in the lower back, and you lose the function to that, then you're going to have a foot drop, you're going to walk with a flapping gait. You might not even be able to feel your legs or even feel your bottom, and even could lose control of going to the bathroom. That's a very severe pinching of the nerves. Otherwise, if you had a pinched nerve, if this nerve is pinched right there, that would be the nerve that go along with the weakness to the tibialis anterior, or what you're talking about, the foot drop. You probably couldn't even walk on your heels at that time.
No, couldn't do that. How about you? You had sort of that progression, and did you have some of those problems?
Oh, yes.
With your gait? Yeah.
I had a high herniation, L2-3, so all my problems were down the front of my leg, and I couldn't lift my toes. I would sometimes start to walk, and my foot would just drag underneath me. It just, like, my toes wouldn't lift up. I would stumble. Yes,
risky.
It was terrible.
Yeah.
And it was just, it alternated between numb and cold. Felt like my leg was encased in ice.
So how long did you live with that before you ended up having to take it in your own hands, or into Dr. Haas's hands?
I started going to a chiropractor the first week, and after 3 sessions in a week, he said, I'm not going to be able to fix you. You need to see a specialist. So
So chiropractic care is something that a lot of, that basically advertises for back care. Chiropractic has some who seem to practice in a way that we can understand as medical doctors, and others that sort of have a fringe type of practice. Any way people can determine whether it's a valid place to go when they want to see a chiropractor?
That is a little bit of a tough call. It's like trying to find a car mechanic. How do you know who really knows what they're doing?
Right.
If you find your symptoms are getting worse, I'd stop. Just like if you try anything else, you should stop that. There are some chiropractors that are very well trained in what they do. Right. And you can usually tell by the results. But like anything else, if you don't see any progression or improvement in a few weeks, then you should consider trying something different, which could either be getting another opinion from either a different chiropractor, a physical therapist, or a physician at that time. But there are a lot of benefit with some of the chiropractic care, and it's very useful. And a lot of the actual maneuvers and techniques are done by some of the well-trained physical therapists. So there are things that chiropractors do that can be very helpful.
Right. And so you had surgery. Was it a tough decision?
No, because I wanted it permanently gone. I had my back injury in July, and we did everything. We waited till January to do the surgery.
Okay.
I did 2 injections. I did physical therapy. We did all kinds of tests. So.
And preparing for surgery, was that a frightening thing? Was this your first major surgical procedure?
Well, it was terrifying because I'd always been told with previous back injuries that it was a 50-50 proposition. The service told me, well, we don't want to do it. It might make you worse. And so, I didn't have any fear of Dr. Haas, but it just in general, going under the knife is
There's a lot of trepidation.
Yeah, there definitely is.
You feel that you don't necessarily know what the outcome will be, but at some point you're in enough discomfort that you decide it's worth a chance.
Yeah, oh, definitely.
And you had your surgery locally, I guess, at Reston Hospital.
Reston Hospital.
And that worked out fine for you.
I'm 100% pain-free.
How long were you in the hospital after your surgery?
5 days.
5 days.
Mm-hmm.
And you recall, was it as traumatic an experience as people might imagine it to be?
No. No, it really wasn't. I knew instantly that probably the day after my surgery that the pain that I now had was surgical pain and not, and it was going to go away. I just
How long did it take to go away?
I took myself off the morphine the day after I got out of the hospital and cut down my Vicodin in half in a week. So I was pain-free in 3 months.
3 months.
3 months.
Okay. And how long did it take you to get back to what you consider to be normal activities?
Oh, I'm better than normal now. I take yoga now, and I'm very flexible, and I feel like I can do pretty much anything.
Great. So did that
6
take
months?
6 months. Okay.
Yeah.
That's reasonable. I think that's a pretty reasonable commitment of time.
Yeah.
How about for you? So here you were. You had what sounds like really awful pain.
Yeah.
Fortunately, something that Dr. Haas said, I think we can fix this.
Yeah. The first time it was the first surgery. Didn't want it, but it was to the point where I really didn't have a choice.
Right.
Dr. Haas says, basically, if you want pain gone, and I couldn't even lift my feet up. Probably about 6 inches off the ground is about as high as I was able to lift my feet. So after that first surgery, big difference.
So you're talking first surgery. That means you had a second surgery.
Yes. Second surgery was the fusion. Right?
Okay.
And
so the first one was to get the pressure off the
nerves. Right.
Okay.
And that gave me a lot of mobility back because, like I said, I couldn't even lift my feet off the ground. I couldn't barely walk. A lot of the pain was gone, but I guess so much of the disc had collapsed, had came out. So fusion, didn't want another surgery. I didn't want a fusion at all. And again, Dr. Haas says, a small percentage needs to have surgery, and I was definitely in that small percentage. Right. And it was night and day. The very next morning, I got up. It felt like I can walk or run down the hall. Couldn't do it, but it was night and day with the fusion.
You would have had to pull a lot of bags and needles with you doing that, right?
Yeah. Bags and places. But
you had to cut back on that pain med to make sure you didn't try that, I guess.
Yeah, but definitely night and day. Like I said, I didn't want the fusion. We did the physical therapy. It worked a little bit. Pain was still there, not as bad as it was beforehand, but it was to the point where, fusion was the only other option, and very happy I did it.
Yeah.
Very happy.
This is probably a good time just to mention about fusions
Sure.
and artificial
Yes,
discs.
you bet.
In Ron's case, he had one bad disc that herniated the pinched nerves. So the treatment for that, if it doesn't get better without surgery, is to take the pressure off the nerves. That was the partial discectomy or the microlaminectomy or whatever you've heard for that.
And you do that fairly non-invasively. It used to be people made a big incision, cut through muscles, and did all kinds of things like that.
Yes.
Now you just use...
Most of the incisions are just big enough to get your instruments in. Might be incision about that big or so.
Yeah, it was actually smaller.
So they're small incisions because the whole goal is to disrupt as little muscle or ligaments as possible and to take the pressure off the nerves.
Right.
And then you get to the issue that you had later is that it wasn't your legs much anymore, it was your back.
Right.
Your discs were shot. Your discs were painful. Not everybody with degenerative discs are going to have back pain. Just because you have a dark disc or a bulging disc doesn't mean you're going to have back pain. But yours kept hurting. We did a test. Remember the test with the discography, where we put a little skinny needle in a couple of the discs in the back. And again, we talked about the discs being like jelly donuts.
Right.
So I put a little needle in the discs, and we found out that one disc didn't hurt. And on the X-ray machine called the fluoroscope, we actually could see that the center part of the disc had that little bit of contrast, like a puffball, and then the other one had tears all over it and reproduced your pain, right? So at that time, since he didn't get better without surgery, that's when we start thinking about treating that disc segment. And the options for that are to remove the disc and stabilize it either with a fusion or with an artificial disc.
Right.
The artificial disc has recently been approved. We were part of one of the first studies to put in and test some of these artificial discs. Very few people are candidates for artificial discs. But the advantage of an artificial disc, and this would be an example of one, you may be able to see that we can put an artificial disc inside a space between two bones here, and that will still allow some motion. So ideally, if you can keep some motion, that tends to be good. The question right now is not necessarily do you want motion, you want your pain to be better. So if you've got arthritis of the joints in the back, if you have osteoporosis, if it's collapsed too far, if you've had other type of surgery, you're not a candidate for this. Somewhere about 5%, maybe 10% of patients that might be a candidate for a fusion could be a candidate for an artificial disc. We know that clinically, if we stabilize the spine, and this would just be an example of sometimes we put metal cages, sometimes we put bone in there, we put some actual donor bone to help get that fused for you. By stabilizing it, by decreasing the motion there, often the pain gets a lot better. If you sprain your wrist, we put it in a splint. It feels better. It's not moving as much. So that would be the treatment you had, was to stabilize that with a fusion. And both of you have had a fusion, and you told me beforehand, despite the fusion of one of the segments, you can still bend forward and touch your toes. Yeah. And you mentioned at the beginning you had a fusion from quite a few of these discs.
I got quite a few fusions.
And
L2
you were out
through
skiing.
S1, and I'm skiing and riding bikes, and I couldn't do that before at all. I couldn't do anything like that, even close.
You probably asked someone, how much motion am I going to lose? Well, compared to a 16-year-old, you have less motion, but you have more motion now.
I look a little odd when I ski,
right?
you know?
Okay.
But I have adequate motion to be able to do what I need to do.
Yes.
And that's, that fortunate. It's fortunate because if you're in pain, it doesn't matter what, you can't do it, period. Now, you had an acute episode. Your car accident was how long ago?
3.5 years ago.
3.5 years ago. It took you how long to the point where you ended up having surgery?
Oh, I've had 3 surgeries with 4 fusions.
Okay. So, and those were progressive and necessary based upon how things changed in your neck?
Yes.
So this was all due to the accident?
Pretty much, yes.
Pretty much, yeah. Tell us a little bit about what it was like to get your neck fused. I mean, that's pretty scary, I suppose.
No.
No?
I didn't think so.
No.
I just wanted to be rid of the pain. And I've had other surgeries, and I knew Dr. Haas, which I thank you dearly for taking all that pain away, and your team. No, I wasn't scared.
Yeah. And you had yours recently?
3 weeks ago, and I'm doing everything now I normally do.
3 weeks ago. Okay. Well, people might be surprised, especially if they understand what the nature of that procedure is. It's a pretty impressive and sophisticated piece of work.
From back here, you can hardly see the incision there.
Yeah.
No, it's right here, and you can't even tell.
Yeah.
There's 3 incisions.
Yeah. It's very, very difficult to tell there's anything there.
And what it does
And you're
is
moving your head pretty well, too. That's great.
I'll adjust to it.
Yeah.
Yes.
That's fantastic.
She did very well.
So what happens with the neck when you do that in the neck? That's a little different procedure.
A little different. In this case, it's the same theory. And if you have pinching of the nerves, then we go and take the pressure off the nerve. Most of the time, the big difference between surgery for taking the pressure off the nerve in the low back versus the neck is that in the lower back, we usually make an incision in the backside.
Right.
In the neck, we usually come from the front. But if the pinching of the nerve is really off to the side, we can come in the back.
Right.
So that it depends on if we can work around the spinal cord or not.
Right.
So most of the time, if someone has a pinched nerve, it's usually from the front, with some exceptions. And we just go by what the MRI and X-rays all show us to see where the pinching of the nerve is.
A lot of information, a lot of interesting stories, and really an amazing world of surgical intervention that can bring incredible relief and really prolong your ability to do the things you want to do, which we all know firsthand for those of us who've had those interventions. If you had to give people general advice about how to preserve and maintain their back, give us some parameters.
Get a good exercise program. It's important to remain strong. Not only aerobic fitness, but strength. You need to get your muscles. Muscles need to be strong. That helps us move. Almost everything we do in our life is short-term aerobic things, going up and down stairs. Very important. Maintain flexibility, remain healthy, don't smoke.
Don't smoke.
Don't smoke. That's a big deal for back pain.
Right.
Those are the initial things. Most people in America do not eat the right type of fatty acids and other types of foods, so we usually recommend some supplements such as omega-3 fatty acids. Those are fish oil capsules. Mm-hmm. We want to make sure we have a good, balanced diet and stay active.
Stay active. Calcium, vitamins, any of those things, do you recommend those? Or
if you eat a good diet,
yeah,
you should be able to get enough calcium. If you get some sunlight, you should be able to get enough vitamin D.
Right.
We are seeing a big issue with osteoporosis, and we're finding that we don't know why, but we're doing, before every one of our fusion surgeries, we're getting a DEXA scan, and we're finding even men are having osteopenia and possible osteoporosis. So we're looking at that, and it's important to have enough calcium in your diet. Weight-bearing exercises. We know that people that, for example, tennis players, college tennis players, their dominant hand have much stronger bones than the other arm that doesn't use it. Swimmers don't have as strong bones than people that actually lift weights. So it's important to do exercises. Otherwise, down the road, we're at a higher risk for fractures, higher risk for other back pain issues.
Great. Well, I thank you all for being here. I thank you, Dr. Haas, for being here, and Virginia Spine Institute for providing a physical therapist and all the other supportive staff that joined us tonight. And I want to thank you for joining us, and hopefully you'll catch us on the next show. But of course, until that time, I'm Dr. Russel Libby, looking out for your health. So.
Thank you.